I think we could start if you're okay with that. Thank you everyone for coming today. It is my pleasure to introduce Eduardo Aguilar, who is the head of technology at Helix Center, and will lead this session. Thank you, Eduardo.
Thank you.
Just one thing, we're recording the session. I hope you're okay with this, but just so you know, and this recording will be made available to you after the session. Okay.
Great. Just one caveat. If any of you have an issue with that, we can either stop it right now or we can edit it. We'll most likely be reviewing it before it's shared. Is that all right?
Sure.
Yeah? Okay. Perfect. Great. So thank you, Sergio. Can I get a very quick show of hands? So how many of you have started a company? Okay. How many of you have either exited a company or had to close one? Okay. Well, that's me as well. How many of you have worked in a company that's 5 people or less? All right. 50 people or less? 5K people? Okay. 50,000 people?
Or less.
Well, yeah. I like your thinking. I really like your thinking. Very nice work. Very good. All right. So what we're going to do today is I've got plenty of stories to tell. I also hope that you'll be sharing some of your experiences as part of the discussion. We're going to have a very quick 1-minute video to kick off the discussion, and then we'll take it from there and talk about the things that are of most interest to you. Is that all right? Great. Thank you. So.
For one submarine, my guys were trained to do what they were told. That's a deadly combination. We all know organizations where people just follow the leader into disastrous situations. So I got my guys together and I said, hey, we got a problem here. I was trained for another submarine. You're trained to do whatever nonsense comes out of my mouth. That's right, Captain. I mean, they knew. They already knew. I was pretty much talking to myself. So I said, what are we going to do? What are we going to do, guys? And we talked about it. Okay, what I really wanted to do was get ready for the inspection. But we were sitting in the wardroom. We spent a couple hours. We were talking about it. And we came up with all these different things. And, well, you Captain, you just got to be smarter. You got to give better orders. It's like, well, I'm going to learn a whole nuclear submarine, miles and miles and pipes. I spent a year learning Olympia, 2 weeks over here. So in a year we'll be safe? That's not going to work.
What do you have to do? Why don't you start? So you have to prepare a submarine ready to go within 6 weeks. You've got people who know how to work within that submarine, but you as a captain have no idea how to work inside.
So you listen to the people.
Okay. Right. Can you elaborate on that? On a day-to-day basis, what does a normal day look like?
So you will arrange for a meeting. Means going by the routine. You will arrange for a meeting.
Okay.
So everyone speaks about it.
Yeah.
Everyone agrees to what everyone has spoken about.
Yeah.
And then you absorb.
Okay.
And ask questions.
Okay.
For the next steps.
Mm-hmm. All right. And can anyone see some limitation with this approach? I mean, it's good, by the way. It's very good. But what can we do to make it more robust? Because at the moment, if you do this, which is great, you're able to do that with however many people fit in the room. So that's not the whole submarine. It's just, let's say, the ones just below you. What happens next?
We can also think from the end side that finally this is the submarine that is going to go in. Mm-hmm. What are the things that are missing?
Okay.
And then start from that way back. Or say what do we actually require for the submarine?
Yeah.
And then go back. Do you have these capabilities? Do you have these capabilities? Do you have this? At least we think this is what a submarine looks like.
Okay.
But that also we don't really know.
Okay. So with that, could you summarize that as having a goal and then figuring out the steps backwards? Is that what you would say?
Say submarine is something that the end user, how you actually be using the submarine and then going back.
Okay, great, perfect. So we have listen, and then use the sub, and then have the how. Right? Very good. Oh, sorry, I pressed the wrong button. There you go. Thank you, Sergio. All right, Jonathan, can you tell us about what do you think are the biggest things to consider when you're trying to operate a submarine and you need to go into a place that might be hostile, you've got lives in danger, and you've just got to operate in a situation where it's not so easy to communicate? Because remember, we can call people into a meeting room every morning, but there's a lot of maneuvers you need to do throughout the day. And we sort of know the gaps, so we have a checklist of what to do. What's next? How do you get people to do things without, obviously, everybody either hitting a rock or getting hit by the enemy?
Oh, well, I mean, you have to organize teams.
Okay.
And, you know, based on their, you know, their specialty or running systems that are critical for the
All right.
submarine.
Very good. Now, let's mix it a little bit. How does the work of one team impact the other? Can you think of an example? Nina?
A submarine example?
So you can think of another example. That's absolutely fine. I have a submarine example. We'll hear about it later at the end. But think of one that you've experienced.
Well, for example, an engineering team can be working on a product feature that the sales team has no use for selling.
Very good.
So you need to make sure that there is communication, like from the very beginning.
What if the communication didn't really happen and you've just joined in? So imagine you join a company and you have a set of features that are being developed and a lot of resources dedicated to that, but then your sales team is telling you, actually, the users don't need it. How do you marry the two from a management organization perspective?
You can create mixed teams.
Mixed teams? Okay. Co-located or mixed in terms of responsibilities? How do you...
In terms of responsibilities, for sure.
Okay.
So you have several different expertise per team.
Okay.
And co-located or not.
Okay.
It's better co-located.
So comms and then mixed teams. Okay. How would you assign responsibilities? So you have, in a RACI scale, responsible, accountable, consulted, informed. How would you split it between, say, for example, the sales and the engineers?
I think that part probably comes top down in terms of the guiding principles of the organization. So,
You're the top.
So if I'm focused on, okay, so in this example, I'm focused on safety.
Yeah.
So whoever, you order them based on who has the most influence on safety, and then that's kind of like the rank in which decisions are taken.
Okay.
Or in Nina's example, if I'm highly focused on consumer needs, then I may listen to the sales team over the engineers.
Okay, so safety and user needs.
Because what I'm trying to get to is like, how do you get empowered people to make decisions without rolling it all the way up by having strong guiding principles?
Okay, so guiding principles, and then the up and down escalation of questions and autonomy. Is that right?
Yeah.
Okay. Can anyone give us an example of a situation that they've sort of been in a similar situation? You've just joined a team, things are sort of not looking very good, but you've got to turn it around. What about yourself?
Not really. Everything seemed to be team side joy.
It's lucky. Okay, that's good. All right. Can you think of an example where it could go wrong within, say, your industry? By the way, we have name tags.
Yeah, there were often where things went wrong. It was around scheduling, in particular. I was an engineer, so getting those drafters were often difficult to get their time when you needed it. So
Drafters.
yeah,
Okay.
yeah.
Can you
draft
elaborate?
drawings.
Okay, great.
To then deliver the output, coordinating all the projects.
Okay, and at the time, who was doing that?
So the individual project managers were having to coordinate it.
Okay.
And coordinate,
All right. So what about the situation where, well, you either have a time constraint or let's say you now have a resource constraint. So you have more things to do than people to do. How do you juggle that?
So that is that situation.
Yeah. And you're in charge of deciding, by the way.
Yeah.
You have five project managers coming up to you and saying,
Okay, yeah.
Sensei, what do we do?
So then I guess you have to have some form of prioritization.
Okay. Trevor, can you tell us a bit more about that?
A prioritization?
Yeah, how would you tackle that? If you have 5 different people telling you, we need to get these resources to get these projects done, it's up to you.
I mean, in the end, I think you really need to think about like what the overarching goal is and how because I mean, you can get lost in the details of these different tasks, but you know, yet again, going back to the sub thing, if the overarching goal is to navigate these dangerous waters, you determine which functions support that goal most.
Okay, great. And let's say we have a goal, right? So, Edgy, let's assume that we have a goal, and the goal is to do what we told from, say, top commandment, but also be safe. How do you pass this message out onto your teams? Because obviously they know they want to be safe, but they also need to do certain things when they might have to take a little bit of risk. So how do you change people's mindsets? Imagine that half of the team here is a bit happy-go-lucky and just wants to run with it.
I don't think I understood the part about the management telling us what to do. Like,
okay. The president of the United States, for example, if you're this captain, they tell you go from here to there, and you have to navigate both difficult situations as well as other people coming at you. How do you make sure that before you go and start the mission, which might be just a couple of days, how do you change the culture of your team to, feel free to assist. You can answer together, by the way. Go ahead.
So I mean, if you as a leader don't know, there are a lot of unknowns for you. I think as a leader, firstly you have to sort of share your vulnerability and say that I'm not the expert. I need you to. We need to work together to do this. I mean, that's it's not about authority.
Okay.
And it's also the second thing is that is to create a sense of safety within the team of whatever actions they're going to take, whatever risks they're going to take. Well, there'll be a process in which they'll evaluate, and the other thing is to look outside in and say, okay, if you take this action, what's the impact? Is it mitigated? Is it limited? Right? If you take this step, so more like how the Navy SEALs operate, because they go into usually ambiguous sort of situations.
Okay.
But the process with which they train, the process with which they support together, they never do it alone. They always do it as a team.
Yeah. Okay.
So it's
ambiguity. I like that. So, Yamini, can you tell us a bit about operating in an environment where you have missing information, including the risk that if you get something wrong, people can die?
So, sorry, what are you?
How do you go through this thinking process? And feel free to step in as well, but let's just give you a little bit of time to think about it. How would you process information, whatever information you have, in order to make a decision that might impact people's lives? So you put their lives at risk if you take the wrong decision, and you feel you don't have all the information you would be comfortable with to make that decision.
I guess I would identify the 2 or 3 things that are most important for me to make a decision. And until I feel like I've got answers to those 2 or 3 things, I keep going and I'm looking for information to satisfy those.
Okay.
And everything else is just noise.
So before we go on to you, what if you only have 2 of those 3 things? And you're not going to be able to get the 3rd. What do you do? Do you take the risk, or do you just pause and do nothing?
I mean, as a leader, I'd have to take a decision, regardless.
Okay.
That is my responsibility.
No decision is also a decision, so that door is still open. I'm just asking.
No, I think it is definitely the job of someone in that situation to take a decision. So
Okay.
that is something I would do. I think one of the things that I like to do is play out the worst case scenario.
Very good. Yeah.
And try and break down the situation into the absolute worst thing that could happen if I make a decision with those two things. And then determine whether or not that's a risk I'm going to take.
So to simulate the worst case scenario in your head,
yeah.
And then figure out what can be done. Okay, great. What about you, Ashwani?
No, just elaborate what she was saying. As a surgeon and as a army man, we think the same way.
Yeah.
And you see, before starting and before putting the first knife or before, we think through what's the worst that can happen. Okay. One is this, what's the worst that can happen? The second thing is we go through the entire process, what we would like it to happen in our minds. Okay. And then find out the critical places where things could go back, and still if we have to do the work, we have to do the work.
Okay.
If somebody is coming with a gunshot, you have to go in.
Yeah.
And just then you have certain damage control steps. Okay, you do it till this time so that your immediate results are taken care of, and then if you don't have the facilities or you don't have the resources to go on ahead, you are not given those things. So you will keep, there will be a sort of a phase one where you can take a step and you can build up the time, and then that's the way the military campaign also goes on. You're not going on. But you don't fire the first step till the time you know that what you're going into.
Yeah. Okay. So you have this attempt to reduce the risk, and then you have a decision point, and then if you do whatever you do, then you have remediation steps.
It's dependent on your previous knowledge and all, but there is always ambiguity. There is always things which will go wrong.
Very good.
You can't dictate quite everything.
Very good. Okay. So how many of you would like to start a new company within healthcare?
Immediately?
Within, say, the next 2 or 3 years. Yeah. Okay, great. About the rest, what is it that you want to do? You want to join a large corporate, is that right? Or you want to do something else? Or is it still undefined?
Both. Large corporate as well as startup.
Okay, which one? And Nina?
Like innovate within larger organizations like health systems or whatever, trying to bring innovation into those systems.
Okay. Very good. So innovation within existing systems. Very.
I did a workshop with Stanford School of Biodesign and sort of using global innovation and design thinking for medtech. So just fascinated about that.
Okay. So you want to go back to that in the future?
Want to go back to that? Just want to learn a lot more about this particular field of innovation.
Yeah. Very good. Okay. And you have something?
No.
Okay. Very similar thing. Okay, great. So for those of you that put your hand up when you said you wanted to start a company, what's holding you back? It's not a challenge. It's just I want examples. What right now is holding you back from wanting to start a company? Sorry, I don't know your name.
Oh, Catherine.
Okay, Eduardo, nice to meet you. It's fine. You can do it later.
Okay.
So you put your hand up to say yes that you want to start a company.
Eventually.
Eventually, that's fine. Yeah. What's holding you back to make sure that? What's holding you back, or what do you think is making sure that it's eventually not right now?
Well, I need an idea first.
Okay. All right. Okay.
Yeah, probably idea and a bit more experience working in the industry. I'd like to probably work with a couple startups and figure out what works well, and then find a co-founding team.
Okay. And is that something that you're pursuing at the moment? Sort of touching. Okay. Great. Good.
Run my ways.
That's fine. That's absolutely fine. Cassandra?
Yeah, I put my hand up, but I actually am already starting a company.
Perfect.
As of a couple weeks ago. So.
Can you tell us a little bit about what you're aiming to solve? Don't have to say how you do it, but.
So our moonshot goal is to allow people with dementia to live independently for their entire lives. And what we're currently working on is developing a technology-based X. TBD. That allows them to do that, either currently helping their carers or helping them themselves make behavioral changes that allow them in terms of like sleep, exercise, cognitive function, facial recognition, etc., to maintain their cognitive functions and their independence.
Okay, so you sustain the cognitive function as much as possible. You stretch that time window, and then hopefully it will last all the way to the end. Okay, great. So in order to help Sandra, can anyone sort of identify certain areas, and I'll tell you why I'm asking this question, areas in which there might be sources of risk. And what I mean by this is, in any type of situation, you have things that you can observe and things you can control, things you cannot observe, or you might only be able to observe indirectly, and then things you can't control, you can only control indirectly or not at all. So what would you say would be things that might be in the non-observable and also non-controllable aspects? So let's start with the non-observable. So one of them, for example, non-observable is at the moment, you don't really know what your potential investors are thinking unless you know them, right? That's a non-observable, you don't know that. So you're aiming to design around that in terms of your experience. What about the users? What about getting it done? What about deployment? What about marketing? What about
economy?
Yes, yeah. Okay, so go ahead.
No, sorry.
Oh, now you have to.
No, just stretching.
Okay, sure.
No, I think even if we cannot do observation, probably we can get some information that we know from the person who has experienced these things. So maybe we can just at least create some plan.
Okay. Yeah, go ahead.
I think maybe one challenge that I think fits in with there is since often technology requires a lot of upfront investment, it's hard to know how people will actually interact with it and actually respond to it. As opposed to some other interventions that you know, you can just do quick tests. And
Okay. So you have the uncertainty of how the product will actually work in the field.
Yeah, like by talking to patients, you can really hypothesize a lot. But until you've actually invested in creating technology, you can't actually know.
Okay.
So there's that risk there.
Okay. So if I understand you right, there's obviously that aspect of knowing what the users want, but also the risk of how long it takes and how much effort and investment it takes to get something that is tangible and as close as possible to the final product, so you get some feedback. Is that right?
Yeah.
Okay. So let's just clear this up. And can anyone think of a term for that very first prototype? Okay, great. So the MVP is primarily used for checking for the product market fit, but before that you have the product user fit, which is, you know, do people interact with it even if it's free? So we have, so you mentioned user behavior and outcomes, and then we have the MVP to minimize time and effort for the first round of iterations, right? So I presume that this is going to be a product that has a combination of many things. So service, so people. You have also software, presumably, on whatever, if it's an app, a voice, and so on. And then you might have some hardware. What would you say are the biggest risks from a time and capital perspective? Go ahead. Demand. Okay. Can you elaborate a little bit more?
A lot of times, I've seen this a lot of times people get into sort of either the science or the product without establishing either of the two things, whether people will interact with it, whether it's usable, which is sort of more the design thinking part, or whether it solves a problem in a meaningful way where people will change buying behavior from whatever is they're using currently to solve that problem to whatever you're doing.
Okay. And so for me to understand that a little bit better, when you say demand, do you mean any demand at all, or demand volume?
It's a combination of, do you have access to the markets, can you attract the users, can you get them to try, can you get them to adopt, will they pay for your product over? So that whole sort of, it's like, I mean the analogy is you set up a restaurant on a high street and nobody walks in, you've done everything possible.
Okay.
Yeah.
And Anand, can you tell us a bit about how you would solve for that, or at least sort of try to plan around that?
So for what it's worth, there's still, I mean, prior to having an MVP, there's research that you could do with potential consumers. So speak to them, get to understand what they would. So if you're looking at setting something up in an ecosystem, sort of who are the key players within that? So if it's patient, if it's carers, if it's family, so see what their needs are and how best you're sort of looking to meet those needs. That research can help shape what the MVP would look like. And then from a quantity perspective, so both what the MVP look like and then how likely they would be to sort of consider adopting something. Then hopefully along that process you sort of keep building towards something.
Okay.
I'm not sure how that would exactly work.
Very good.
But sort of gauge likelihood to adopt across the process.
Okay, Nia?
You also have to figure out who's going to be paying for it and
Okay.
what their needs are. So is it going to be the caretakers who are paying for it? Is it going to be insurance that's paying for it? And what results do they need to see, or what proof do they need to actually adopt it?
So you've touched on 2 points there. You've touched on both the who will pay, because in healthcare a lot of the time it's a bit of a triangle. You have the manufacturer, you have the consumer, so the person that pays for it, and then the user, the person that plays with whatever you build. And in this triangle you then need to balance how you transfer value across them. So obviously you give value to the user by giving them the product, and then that results in some value to the consumer, and then the consumer sends you the value in form of money. So in this triangle here, let's call them manufacturer, user, and consumer, right? So you have the product, savings, and then this is, say, money. Now, can you elaborate a little bit on the proof? Because this touches on the topic of metrics. How would you think of designing the metrics that you try and track?
Well, you need to show cost savings for the payers.
Okay.
And so you need to show basically how creating independent people who would otherwise not be independent would save costs for the payers.
Okay.
And I guess you would do this by, I have no idea.
Okay, very good. So I saw a few hands there. Edzi, go ahead.
So there's this one example that I can think of from the company which I will be working for, but they are trying to come up with this application which makes it easier for diabetes patients to keep up with the data, like their PG data, like all these other things that they need to keep track of. So it creates a connection between the healthcare professionals, like their physicians, and sales reps of the pharma company, and the patient himself, because they also have a historical data of what they have been experiencing over the.
Okay. And would you, do I hear you right in saying that the product actually is the one tracking the metrics? Is that correct, or you do it indirectly?
So it's either, it's like an app. If you are wearing a wearable technology, you can record it on that, or So.
Okay, very good.
Does that explain?
Yeah, I think. I think you had the feeling that you didn't quite.
It's still on the idea stage, so I wouldn't necessarily have the old details about how it works, but the whole idea is, it stems from the fact that they realize there is this certain cost for patients, diabetes patients, not really tracking their blood glucose levels, so that results in last minute complications, which in addition to all the other costs,
so
create an incremental cost to the whole system. So that's where it actually starts. To your point, that's what I was thinking. They could justify that it will decrease the costs for the whole ecosystem by tracking.
That's very good. So if I can very quickly summarize, correct me if my understanding is a little bit off. You have a pretty good idea of how something happening causes a saving, causes an improvement, and so on. You wanted to add something?
Yeah, I actually do have a similar example from a company. A startup I was working at that would provide care to the like top 5% like sickest people of an insurance group in the U.S. and those people were known to on average be admitted to the hospital like 9 to 15 times per year. And so by introducing a new product, if you can prove that those hospital admittances go down drastically, then that could be a way of showing, cost savings.
Okay.
One step.
And am I right in understanding that there's a time delay between the use of your product and then the benefits?
Not necessarily, actually.
Okay.
And so the insurance companies already have the data, as you said. They already have the data on the patients, and so if within the first year of using your product, you can show that they've been admitted to the hospital much less. In our case, they were admitted 1 to 2 times per year. Within the first year of using our services. And that's pretty immediate results, I would say. And that's cost savings for the parent.
And Sergio, you had something over there?
Yeah, well, I have a biased view of this thing, but whenever I'm thinking about who pays for this kind of services, I think it's really relevant to bear that in mind, because if you're thinking of promoting independence for the patients, but then what you are providing is cost savings for the insurers, that creates a misalignment for me. I was seeing Omada, this company, Omada. It's really nice. They do these behavioral changes. They enhance your autonomy, but you cannot sign up as an individual. You have to go through your health provider. So that creates a disconnect for me. So maybe you have to choose. Either you create value for the insurers, or you create value for the patients directly.
Okay. Go ahead.
I think you need it for both, because the patients, no matter how much value you give to them, they're not necessarily going to pay for it if they see their insurance is already, like if they're already paying money to insurance or they think that should be provided. So I think it's impossible to get adoption if you don't have the buy-in of the people who are paying for it. And it should be aligned though, like the insurance company should be saving money and the patients should be benefiting. So in that way, they're both, it's an advantage to both of them.
Well, as I said, I maybe have a bit of a contrarian view, but sometimes patients tend to see insurance companies as a bit of like the enemy, and doctors definitely do. And so you can sell as a service to the insurance companies, or you can create a sort of resistance. Maybe you can be autonomous and rely less on your insurance company as a person. Maybe that creates also an opportunity, and it's a different take. I don't know, but...
Okay.
My experience is that as far as preventive programs are concerned, like what is happening in your cases, there the patients will not pay. It's where you don't get an immediate return from your investment, you won't pay. Okay, you've been told all the time that go to the gym, go to this, you won't do it. You are not seeing it in the immediate results. For that, you require the insurance to pay you indirectly. If the insurance insists that you wear this device, which will help you, help future complications will prevent future complications, and if you keep on wearing this device, we will reduce your insurance premiums. Then the patients will take it. Otherwise, the patient will not pay unless he gets immediate. If you don't get the candy immediately, you will not pay.
Okay. Does anyone have anything to say about the? Go ahead.
So I think if you're looking at what the benefits are in terms of this triangle to work, so I think one is patient outcomes, which is obvious.
Okay.
Patient outcomes is, do they get better quicker out there? This provider outcomes, is it cheaper for the hospital? Is the bed turn run better? This provider outcome, and that could be time, effort, money. Or anything in the value chain. The third is population outcomes, which is back to the wellness rather than the illness part of it. Is that something that sort of improves the well-being of the population rather than just the
So there's a phrase that is often repeated. Is it a Vicodin or is it a vitamin? And I think that this question sort of applies here. You mentioned wellness versus illness. What are the societal changes in terms of value that need to be done sometimes in order to change people's mindset towards being a healthy individual rather than only getting infected when they get sick. The reason why I'm saying this is because there's already a market for sick care. There is a market for super high performance, super high fit, wellness, elite people. But there's this big group of people in the middle that if they get a little bit worse, all of a sudden cause a lot of harm to the infrastructure for sick care, and could also be, you know, a venture opportunity for you guys. So, your example, Cassandra, would you consider that sick care or wellness?
I think there's two places that we could target. I think one is people with dementia who are very dependent on their carers, and so the problem there is care fatigue, either because they don't understand the symptoms or how to manage them. So developing a tool that helps carers care for already very dependent people with dementia, but then you could target more earlier down the line and say people with early signs, if you start on the program earlier, then you won't get to that stage where you're dependent. So then that's a little bit more on the wellness side, depending on how early you target.
Okay, so if I hear you right, is that essentially with this problem that you're trying to help solve, you have two approaches. One is capture people that already are having problems, and then the ones that might start getting them further down the line. Which approach do you think you should take?
I was going to say, well, I think capturing them earlier, just because with the coming from the wellness angle, you don't necessarily have to. You've got the opportunity to really like drive a customer base to be willing to pay for it for themselves. Particularly, I think with our generations that are getting older, there's a much bigger movement. We're a lot more health conscious, I think, than maybe people that are in our parents' generation. And I know this is probably a few years down the line for what you're looking for, but I think that people are willing to try these things these days. We live in like a technology age, and I think that you have getting around all the complexity around healthcare payers is going to be really difficult, and maybe going for the wellness, a broader customer base that are younger is maybe the better direction to go.
Could you repeat your question again, please?
So she has a goal, which is to help the people that are going to live with dementia live independently for longer. Now, there are essentially two target groups. There's the people that have already been diagnosed with dementia and are very reliant and dependent on their carers. So people that are having the problem now, so high pain and maybe less you can do to help. And correct me if I'm wrong, by the way. And then another group altogether, which is the people that have just been diagnosed with early onset dementia, are still going to work, not dependent on anybody yet, but could benefit from some of her products that would help delay the onset, as well as extend their quality of life for longer. So which one should we target if you just need to pick one as a startup?
Yeah, I'd like to make a comment that prevention versus therapeutic, that is the debate, right?
Okay.
Sick care is therapeutic and prevention is the awareness.
Yeah.
So in terms of the numbers, for any ailment, prevention is a bigger market than the therapeutic.
Okay.
There will be more who have symptoms than those who are diagnosed.
Okay.
But in terms of the value per patient, the therapeutic will be bigger than the prevention.
Okay.
Now, if this, as she said, that if it is dependent on payers, if this dementia treatment is dependent on payers, the payers are attracted to only therapeutic. Payers, be it a government or be it an insurance, they are more attracted towards therapeutic because the value is there rather than preventive. Like in NHS, as I know, it's hardly a 10 to 20% of the budget goes for prevention, 80% budget goes for therapeutic.
Okay.
Prevention is underlined assumption that patient should take care of himself. Or means ideally, that's what the government's assumption is. That prevention ideally should be taken care by the public bodies or awareness campaigns. We are not going to help with any service or the products.
Okay.
So service and products are paid by the patient themselves.
Okay.
So I would strongly recommend in this case a therapeutic route rather than the prevention route.
Okay.
To gain immediate dollars.
Immediate dollars. Let's continue that. So you guys can decide which one goes first.
Okay, I wanted to cast a slightly different view on this because I think on a single patient basis, the cost effectiveness will be greater in terms of quality adjusted life years for those who will have sort of the early symptoms of dementia rather than those who have full onset already, because the additional cost of prolonging 1 extra year of life or independent life for them is much higher. So from a payer perspective, I would be more interested in actually targeting those where I can have a greater impact for a single pound or dollar, and in that case, that would be the former group.
Okay. Go ahead, and then you can both go.
I really like your take, thinking about therapeutic and preventive. I think there's sort of way to look at it. Is if you think when people are sick, they tend to rely on any system or think they have already paid for. Whereas there's the preventive thing that doesn't sound really attractive, but if you change it to self-improvement, there's massive amounts of money being spent on people trying this new program to get a bit stronger, to get a bit faster with the minds. So you can tap an enormous single patient payer market where everyone will pay for this service as they feel that they're improving themselves, and I think that's a great opportunity.
Okay. Yeah.
I think I was just on the kind of therapeutic versus preventative thing. For payers to approve to pay for these things, and we talked about it before, is the data, or like whether you've constructed some sort of study or whatever, you have to really be able to prove the value of your product above whatever the standard of care is at the moment. Whereas if you're going for the preventative more, I agree with you, the patient trying to improve themselves, there's less emphasis on you needing to really be able to, I guess, demonstrate a huge value that improves outcomes as well as.
So if you're doing prevention, you need you need less rigor in terms of demonstrating that you are going to provide some value. That's interesting. Okay, Nina. You forgot?
I've gotten distracted by it.
Okay, Vern?
Can I follow up on that?
Yeah, go ahead.
With a question. So, one of the benefits I think of targeting the later segment is it's probably easier, I would assume, to monitor the outcomes.
Okay.
And therefore have evidence for validating your product or solution versus early. Are there any thoughts on that for folks that have like more of a?
I think if you get the early patients and you have you need some sort of diagnosis in a scale, then you have a Kaplan-Meier graph telling when they become dependent. If you're able to demonstrate that they live longer as independent, it's going to be really easy for you because you're going to be tracking them. You're going to have the scales that are going to tell you which stage of dementia they're in, and if you're able to demonstrate a longer life, a longer independent life, it's going to be easy. And you have to deliver perceived value also, and they're going to get better.
It'll be over like 20, 30 years though, right?
Yeah. Vern?
I think the decision is not simply a rational one, because if you look at, I'll take an analogy, if you look at psychology, right, for repairing people with mental problems, been there for hundreds of years, for 100 years, and you've got positive psychology, which is a completely different discipline. It's not the opposite, it's a completely different discipline of what makes us happy and keeps us. So I think this is more about the purpose of the company. It's more about what is that drives you, which side of the line do you use, because this is not a spectrum. So it's not a continuum. What side of the line do you sit on? Do you believe that people can take charge and be healthy and sort of extend out there, or do you want to fall into the fact that there's money in this ecosystem and I want to share of it? Therefore, let me get into it. I think the decision is not simply profitable segments. I think it's more about the purpose of what drives you as a business.
So that's a very interesting point. When you're in such an early stage startup, you might actually want to define that spectrum, and instead of saying where do I sit, is where do my customers sit. So you might actually go for the believers first, and then early adopters and so on and so on and so on.
I wasn't talking about that.
Okay.
I wasn't talking about how you would sort of grab the entire market and where your early adopters are. I was talking about where your ethos is.
Of the company.
Where is it that you want to make money? Do you want to make money? So there are a few doctors I know from King's College who are completely turning around and say we don't talk about nutrition at all. We don't learn nutrition in in medical science. We always talk about repair, so they're sort of setting up startups completely focused on the wellness side.
Yeah.
So different ethos. It's like how how am I going to make money? So yeah.
Okay. So Anand, can you tell us a little bit about the runway she'd need if she was to take the approach of catching things early?
So when you say runway, what sort of?
So given that you have to build a product, then after that you need to put it in front of people, and then after that you need to have some form of a demonstration that it generates positive outcomes.
Okay.
What would you need to do if you absolutely need to show positive outcomes, and what can you also do as a workaround before you show positive outcomes?
So I think, thinking from what I could say is an idealistic perspective, I think you'd probably start with to whom do I need to convince that such outcomes make sense, and what are those outcome metrics?
Yeah.
So again, I'm thinking more on paper than from real life experience, but defining the outcomes, defining the stakeholders I need to convince, and then understanding how long is it actually going to take to generate the data or the evidence, because we're looking at the early stages, as folks said, it's about the 20-30 year window, so at what point does it make sense to pause and take a time check, or what is measurable, and sort of understand what we can attribute as well to this intervention versus what other things we might be doing. That would probably be the starting point that I could think of it. Further down the line, along that process and seeing how it plays out is something that I would probably do.
Good. Does anyone have... Go ahead, yeah, sure.
Actually, I wanted to challenge the assumption that we all just took for granted, that the big dollars and the earlier dollars are in the therapeutic sort of approach to things instead of the preventative. But if you consider what falls into a therapeutic, and you consider that actually you have to prove it, and you have to probably do clinical trials, and then it's a therapeutic, everything else falls into the preventative category. So even if someone already has Alzheimer's or dementia, whatever dementia form it might be, and you're giving them something that isn't proven via a clinical trial, it becomes a wellness product, it becomes preventative again. So maybe that's actually where the early dollars are to be made, because it's easier. Does that make sense?
Good. How much does early dollars keep you up at night?
It doesn't.
It doesn't. Okay. So what keeps you up at night?
What keeps us up at night is the fact that there are a lot of people who deal with dementia that don't understand it. So a lot of primary carers that don't understand it, and therefore are exasperated and frustrated. But they're the carers, so it's not good for them as the carers, and it's not good for the people with dementia.
Okay.
So just knowing that there is this huge problem there that can be solved by not rocket science. We're trying to scale the impact that my co-founder currently has working one-to-one with people. So.
It's great. Jonathan?
Well, I mean, it seems also that the metric isn't about the therapy, because you're not treating the dementia patient, you're just helping their living situation. So it's a product that's around healthcare, but it's not healthcare itself. Or it will impact healthcare, but it'll be. You should have metrics that are not therapy based, but sort of autonomy based, or
independence, autonomy.
Yeah.
Quality of life.
It's almost like a little bit of a dementia advocate.
Yeah. Okay. Very good. Anyone else? Yeah.
I'd like to make 2 points, which is very true. This is a unique ailment, Alzheimer's or dementia. So you don't cure, you control it. As a therapeutic, it doesn't mean that you cure it outrightly, because it hits you at such a later stage in life. And the element of early dollars, it's not the size of the market. Size of the market of cure will still be smaller. It's the profitability which is significantly higher. Because understand, when you are sick, the price sensitivity dramatically drops compares to when you are getting aware. And for an organization, if you are in the awareness spectrum, you need to be really good in terms of marketing your proposition. In terms of therapeutic, you need to be good at R&D. Marketing can be taken care of. So these are the different, as he said, the skill versus will thing.
Yeah.
Like you have the willingness that I want to make the society Alzheimer's free. So let's work in prevention. But if you don't have the skill in marketing, it will not work out. So you have to find out also your skill, the kind of people you are working with, or the kind of technologies that you have, or the development you have done so far. I think means it's personal opinion purely.
All right.
So it's totally dependent on that. The capability, the size of market, and the overall purpose.
Can one of you build up on that? So if I could rephrase that, so you would first focus on profitability, and then, well, at least in your business plan, and then don't worry too much about marketing. Get the R&D to be right, and then marketing will take care of itself.
I would say first worry about the market which you are going, and the need of the market, as we listed earlier, and then decide whether you need more of marketing or more of R&D.
Okay, good. Fine. Now, assuming you could take 3 routes, you build something that's a service, you build something that with people, you build something that is software only, like say an application, and you have something that involves hardware, like say sensors in the house or cameras and so on, or any combination of the 3. Which one would you start with? And please elaborate as to what made you lean towards one versus the other, whether it's, and then I'll leave it.
Can you reiterate the 3?
So service, so humans doing work, software doing work, or hardware doing work, or a combination of the 3. Yeah, go ahead.
Probably start with people, kind of like how you have with your vendor, to get a baseline of what the need is and what the human need is, because without that kind of ethnographic research behind your idea, you might be building a tool when you don't really know what problem you're trying to solve.
Okay. And then?
And then you could expand it to have an application that supplements or allows you to scale beyond what you could do with just people.
And if you were to choose between software and hardware, what would your business considerations be there? Business and pro.
I mean, investment costs, obviously hardware is a way higher investment cost. And then also buy-in. I think that people are more comfortable with that first step being software versus hardware. Seems like a bigger jump for people. So my guess would be that you'd have a lot higher adoption of software versus hardware, at least at first.
Okay, good. Yourself?
I think the question between software and hardware is more related to the specific use case and what the either behavior change or problem solve. Like how big that is. So with hardware, I could imagine something being on a healthcare spectrum, like literally a test. That hardware might be designed to be perfectly in line with that test, such that previous hardware, so incremental innovation, previous hardware wasn't able to do, or you had to go to a clinic to do it. So something, I know diabetes, like blood sugar testing has gone crazy. Such that tiny hardware can do a lot there, whereas software, how's that going to do that? But in software, if it's another app getting you to do something that's very tough behaviorally to change, it may not even make sense. It's much rely on people dimension a lot more than just an app.
So on the topic of adoption and behavior, Claire, can you tell us a little bit about what you think would be the things to watch out for?
Adoption behaviour. So I think it's been mentioned a bit already, like if you have stronger incentives, you're going to be able to drive adoption behaviour, and so that might be coming from the insurer in the form of reduced premiums. And then, I mean, it's pretty tough to change behaviours, especially if it's preventative health measures. So in which case you need a really strong value proposition to demonstrate.
Nina and Sergio, and you. Sorry, how do you pronounce your name?
Wojtek.
Wojtek. Okay. You guys can decide. Well, you put your hand up first. Go ahead.
I was gonna say the biggest hurdle I see is getting caretakers to adopt it, since they are the decision makers, and if they're already feeling very exhausted from everything that they're doing for the patients, getting them to start tracking or interacting with it could be seen as something extra. And And so figuring out how to like sell that value proposition to them seems like something that will be hard.
I see you nodding. Is that more or less what you were going to say?
I'm thinking along those lines.
Okay.
You have to think of also the ease of use, because most of the caretakers, they're also in ages that are close to this kind of problems of dementia. So I think you have a great opportunity now with the voice as an interface, like using the Echo Dot or something, that will allow them to communicate with your system without using a screen or a device that is really complicated for people in all ages. So I will leverage that. You already have the help.
Good. And your point was?
Yeah, just to add on that, I think it's not only the problem of adoption, but then also compliance over time, since especially when you're trying to prove the impact, you need regular, consistent data over long periods of time, and compliance, especially for older people, might be difficult, which is where I guess the tension or trade-off between having just software or also people involved can become critical, because having a person delivering the service in some way is probably more effective, but also much more costly. On the other hand side, if you think about scalability, it's obviously much cheaper and easier to scale with just software versus having people on the cloud.
Okay, great. Kim, I see you thinking. I wanted to ask you a question. If you were to pick any geography in the world, where would you go first in terms of the culture as well as the cultural societal need in order to guarantee that you have the right adoption and the positive behavior to take this on?
Probably to industrialized countries. Some that are not too conservative.
Okay.
Quite open to change.
Can you give a couple of examples?
US, UK maybe.
Okay.
Yeah. I'm from Switzerland, but Switzerland is quite conservative, so it takes a lot of time to change behaviors, although it's supposed to be a very good market for healthcare.
Yeah. All right. Go ahead.
Scandinavia.
Scandinavia. All right. Please tell us why.
Behavior change, I think, is more flexible depending on, it really depends on what it is, but I think that, you know, highly developed, industrialized, but at the same time open to adapt to new technology. I think that's, or Australia actually. I think Australia is a pilot for a lot of behavior change type innovations. It's a common pilot.
Okay, interesting. You had something?
I think it will be US, because the power of the internet and the power of the television is so much more over there as compared to the other places that you can, if you can get a good segue into these two segments, you can really change. You can get into the adoption very faster than other places.
Okay. So quick question about the US. If you were to consider, you're going to have, obviously, it's a single market in terms of economy and so on. Different states have different rules. Different people have different insurers. What's the trade-off there between the uniformity of the country and the culture to a certain degree, and the fragmentation of the people that would pay for it? Nia?
Yeah, I see a lot of issues with the U.S.
Okay.
because with willingness to pay, because individuals don't want to pay for health care because they're already paying so much for health insurance, so they don't want to pay anything in addition to that. And then for the payers, if you want to approach insurers to pay for it, then they're not motivated, because usually patients are not staying with them long term. There's a lot of turnover, and so they're not necessarily willing to invest in long-term outcomes.
So you seem to know this quite well. What tends to happen when people retire? Because normally the healthcare is paid by the employer, but once they retire, they're
on Medicare.
Okay. So what does this mean for this group, the user group?
So Medicare would be a good payer for it.
Okay.
But Medicare doesn't have the most money.
Okay.
So it would be, I mean, it'd actually be a great test group. If you approach it the right way. And actually you could, because there are like private insurance companies that Medicare contracts to. So you could start with a test with like Humana, for example.
Okay.
So it's possible, but it's complicated.
Complicated, all right. Kendra?
Yeah, I was going to say, I think Medicare is, in the US at least, a lot of companies target them specifically as a pilot, because it's like kind of a consolidated group that all has like centralized payment in some form. But I kind of see the problem with that is that it requires a ton of data to sell into a group like Medicare. Whereas if you were trying to sell somewhere where it's more personal pay, like I'm making this up kind of, but I believe that in India there's a lot more individuals paying for their own healthcare, and there's a growing middle and upper class, and they have a stronger family unit where people are probably taking care of relatives, maybe even more so than other countries. So I would think somewhere like that where people are doing personal pay already, and so this would just be another thing that's part of that personal pay might be a better way to go.
Okay, so you mentioned a topic which was to do with volume, the number of people. How many people do you think you'd need in the first year and the second year in order to demonstrate that this has legs and can go forward? Because obviously, you know, with Medicare, as soon as you crack that, you can access millions. But you might not go for millions in the first year. So if you have a smaller number, maybe you can be a bit more picky and you have more options as to where you can go. What volume of user group do you think you'd need in the first 12, 18 months? Anyone? Okay, let's throw numbers at 1,000, 100,000, 1 million users. Which of the three?
Preventive 5,000.
Okay, preventative.
Preventive 5,000. If there's a therapeutic option, even first 50 would be, you can predict it.
Okay,
But,
great.
Preventive 5,000.
And what do you think that is?
Why?
Thank you, by the way. Why 5,000?
This has been the trend for preventive issues.
Yeah.
I know from practical thing that this is a good sample size for proving that whether the thing works or not for preventive purpose.
Okay, great. So just to sort of wrap this up before we show the video, because I think that we're sort of reaching the end of the session, who would you need to convince beyond your users, and that's also the reason why I touched on the number of users, in order to say get the second round of funding, right? So you're obviously going to have to convince the next wave of users, but also you're going to need some more cash, quite possibly. So if you're going for VC, what do you think the VCs would look at? I mean, is it 5,000? Is it 5,000 if you have a big change, or is it 20,000 if it's a small change and improvement? How would you go about it? Uni? You have to pitch tomorrow. What's your target? Would you put 5K and then say we'll change it later, or?
I think it's like what you said. You need to gauge. It depends how effective, when your product's been tested, like how effective it's been as to how much impact you have a sense that it's going to have. As to how you would pitch it. I don't know if you can put a number on it unless you know.
Okay, so the reason why so go ahead.
Well, I was just going to say, the smaller the change, probably the more people you need to show, okay, well, even though the change is small, look how widespread it is.
Yeah, okay.
And then also with investors, my feeling is that you should always undercut your goals.
Yeah, okay.
Like make them smaller rather than bigger so that you meet your targets and get a second round of funding as opposed to
So under
not
promise
meeting.
and over deliver.
Exactly.
Okay, great. Anything else? Right, so I'm just going to show this, and then I'm more than happy to have Q&A, and we'll basically take from there. For 1 second, I'll fix this. Sorry. Should I try?
Learning Olympia, 2 weeks over here. So in a year we'll be safe? That's not going to work. We had to deploy the submarine in 6 months. So we talked about it, and they said, okay, there's only one logical solution. We figured it out. They're pointing at me. You, shut up. What do you mean? That's not what captains do. That's not what captains of nuclear submarines do. They walk around. They give orders. They sound like Russell Crowe. Head 2/3, dive, make it up 500 feet. Helm left 15 degrees weather, steady course 255. Load torpedoes and tubes 1, 2, 3, and 4. Slide down, open outer doors. Right? And I thought about it. And you know what? They were right. So at that point, I vowed never to give another order. And if you came down on my submarine, it would have been very confusing. Because you couldn't have pointed. It would have been hard to say, well, who's the captain here? Because you wouldn't have seen me giving orders. I did retain one order. The final order to launch a weapon, a torpedo or a missile, I kept with me because I felt since that was going to result in the deaths of other human beings, that I didn't want that on anyone's conscience but mine. That was my moral and ethical responsibility. But even though everything else, in the Navy there's long lists of things that says the captain has to authorize. Captain should authorize. You got a couple nukes in your group, they'll tell you it's true. Captain authorize, submerge the ship, get underway, start up the reactor, shut down the reactor, connect to shore power, divorce from shore power. On and on, break product, on and on and on. Pages of these things. I just refused to give those orders. What we replaced it with was intent. Instead of giving instructions, if you want your people to think, don't give instructions, give intent. So they're kind of, hey, what do you want me to do? Well, left full rudder, steady course 255. No! So what are we trying to accomplish here today? Well, we're trying to get in position so that when the enemy submarine comes through, okay, so where do you think we should position the ship? Maybe over here. Good idea, go there. You give intent to them and they give intent to you. So my officer stopped requesting permission. And every other submarine, Captain, request permission to submerge the ship. Submerge the ship. Submerge the ship, aye! On Santa Fe, Captain, I intend to submerge the ship. Very well. And they did it. And it might seem like it's a very small, nuanced change of language, but it was hugely powerful because the psychological ownership now shifts to them. They need to discover the answer. Otherwise, you're always the answer man. You can never go home and eat dinner. And so we started doing this. And it was hugely powerful. Actually, we went another step. Then I got smarter and I said, when the officer said, Captain, I intend to submerge the ship, I would ask him, well, what do you think I'm thinking right now? And he'd look at me, hard to tell. I'm guessing you're wondering whether it's safe. Bingo! I said, well, convince me it's safe. He said, Captain, I intend to submerge the ship. All men are below. Hatches are shut. Ship's rigged for dive. I check the bottom depth. The submarine's in the water that's been assigned to us. Then later I would ask them, is it the right thing to do? And they would say, well, yes, sir, because our mission requires that we... And these are the two pillars that I think support this idea of giving control. These are the two pillars that need to be in place. The technical competence, which is represented by, is it safe? And the organizational clarity, which is represented by, is it the right thing to do? And you put those things in place, and then you can give control. And you give control, and you put those things in place. And you are off to the races. So think about what's happening now. My officers are starting to think like me, because they have to think like, where should we do the ship? And so the guys below them. Now this took 24 hours to happen. It took a couple years for the full implementation, but immediately there was change. The officers are thinking like me, so pretty soon they go in the engine room, find the engine room lower level watch who was taking logs in the lube oil pumps, and he would know what the submarine was doing. He would know whether we were up tight, close to the enemy, it was time to stay quiet, or whether we had backed out a little bit. This may be a good time to change filters and make a little bit of noise. A year later, we received another inspection. A year later, we received an inspection. The inspecting team gave us the highest grade they had ever seen. Not that year, not in the Pacific, ever seen. Why? I mean, this crew had a captain who was a dummy. It's because that needle started moving up. And on another submarine, there was one guy in charge, one guy giving orders, one guy thinking, and 134 people doing what they're told. I don't care how smart you are. On my submarine, I got 135 thinking, active, passionate, creative, proactive, taking initiative people. It's a tidal wave. You don't stand a chance. Here's the solution. Move the authority to where the information is. You mean the software engineer can decide whether we ship the software? Yeah. You mean the client, my salesman, can close the deal? Well, up to $1,000. No. Yes. Whatever the price? Yes. What does it take to make that happen? Now, if you're picturing a lot of people out there doing crazy things and a bunch of arrows going in a bunch of different directions, you have the wrong picture. You create the environment so that those people are out there making decisions as if the CEO were standing right behind them. And if it's not the same decision, it's actually a better decision because they have the information. And not only will you get better speed of execution, because now you don't have this delay, what happens is those people feel like they matter because they're thinking. You engender thinking. You create the environment for thinking. The secret is, nothing I said is hard. There's nothing hard. The only thing that's hard is you. It will feel wrong. You've been genetically and culturally programmed to take charge and make it happen. Take control and attract followers. And what you want is to give control and create leaders. It will feel wrong, and you will repeatedly start down this path if you so choose, and then you'll be angry at yourself like I was. And you will have a failure, and you'll go back to the old ways. You will pick yourself up, and you will go again. You will go again. And by doing so, you will achieve the greatest thing possible. You will have achieved greatness, not because of the deeds and acts that you did, but because you set an environment where the people around you and their families and their schools and their organizations and their businesses, they've achieved greatness. That will be the greatest thing of all. Go forth and be great.
All right, so one of the reasons why I showed this is primarily because healthcare can be extremely complicated. And as a startup or as a business person starting in this area, you will have moments where you need to relegate control where the information is. So I just wanted to give that as a little leaving note. Thank you. I'm going to stay for a little while, so if you have any questions, that's absolutely fine. If you have to go, that's okay. Thank you very much for coming, and I hope it was helpful.